Hello, my name is Pavel. I'm from IDEAS Training Network, working in improving statistical methodology in clinical trials. In this short video, I will tell you about some challenges of early phase dose-finding trials in oncology. Before a new drug can be tested in many patients, it should be checked that it's safe. And phase 1 clinical trial is first-in-human study evaluating a basic safety of a drug. A new drug is developed to treat patients, but it can also cause undesirable adverse events. In oncology, where no treatment can result in death, some of these adverse events can be tolerated without any concern, for example rash, but some are more severe and life-threatening. For such adverse events, it's required that only a small proportion of patients' population would experience them. And the question is how many of these adverse events can be tolerated. Conventionally, in oncology, the drug is still acceptable if it causes adverse events in not more than 1/3 of the population. Then a phase 1 clinical trial aims to find this upper bound for the toxicity beyond which dosing regimen of the novel drug is unacceptable. So, how does it work? Imagine that we are given several doses of a novel drug, which are displayed on the horizontal axis, and we would like to study the toxicity of the drug displayed on the vertical axis. For many drugs, it's natural to assume that more you give, the higher the treatment effect, or in other words, the more the better. But also higher the chances of the adverse events. This increase corresponds to increasing red toxicity curve. We know that the dose which causes adverse events in more than 1/3 of population is unacceptable. But because the more the better, we would like to find the highest acceptable dose. For this, we draw a horizontal line at level 1/3, and then we look for the dose corresponding to this level of toxicity. This is exactly the target dose that we would like to recommend in phase 1 clinical trials for further investigation. Then the question how to find this dose arises, and medical statistics aims to answer this question. There are two main approaches to find the target dose in phase 1 oncology trial. The first one is rule-based. The idea is to define a specific set of simple rules how to enroll patients in the study. One of the most well-known rule-based designs is 3+3 design, which looks as follows. We enroll 3 patients to some dose and observe whether they will experience severe adverse events. If no adverse events are observed, next 3 patients receive the next higher dose, or in other words, we escalate the dose. If only 1 out of 3 patients has experienced adverse event, the next 3 patients are assigned to the same dose. Finally, if 2 or 3 patients have experienced severe adverse events, the next 3 patients will receive a smaller dose. In other words, we will de-escalate the dose. The study proceeds like this until all patients are enrolled. Clearly, such design uses information from the most recent 3 patients only and ignores all other knowledge that we have received already in the study. Therefore, it was found that while being simple and clear, it leads to poor performance and can be improved. The improvement can be achieved by using the second approach, which is called model-based. The idea is to use all information that we have already obtained in the trial and to use some simple model to fit dose toxicity relationship. Coming back to our dose toxicity graph, the idea is to fit a simple curve, for example a linear one. Although such approach does not usually capture the whole shape of the dose toxicity curve, it is not in fact required. In phase 1 trial, we are interested in fitting the curve in the neighborhood of the maximum tolerated dose only, and such simple model is rich enough for this purpose. Consequently, this approach was found to lead to high probability of correct recommendation in phase 1 clinical trial. However, fitting a simple curve can be done in a setting of single-agent trial only, where it's known that higher dose corresponds to higher toxicity. This can be much more challenging in more advanced clinical trials that start to attract more attention nowadays. Such challenges arise, for example, in combination trials. To illustrate this challenge, imagine a trial with 2 combinations only. The first combination consists of 3 pills of red drug and 2 pills of yellow drug. The second combination consists of 2 pills of red drug but 3 pills of yellow. This means that in such combinations the amount of one compound is increased but another one is decreased. Decreasing amount of red drug is expected to decrease toxicity, but increasing amount of yellow is expected to increase it. In many trials, it's impossible to say before the study which of these effects is greater. Therefore, it's unclear which of these combinations is more toxic. Furthermore, it can happen that both of these combinations have the same maximum acceptable level of toxicity. Can we find in the study that both of them fit our definition? In fact, finding all possible combinations is a much more challenging task than finding a single one. One more type of clinical trial in which unknown toxicity relationship arises is dose schedule studies. For the illustration, let us consider an example of the trial with 2 schedules only. The first schedule is a 6-day course of treatment in which 1 pill of red drug is given to a patient every day. The second schedule is a 6-day course as well, but now a patient is given 2 pills of the red drug every 2 days. Comparing these 2 schedules, it's clear that the amount of drug received under both schedules by the end of the day 6 is equal. However, twice quicker administration is expected to increase toxicity, while twice smaller dose is expected to reduce it. In many trials again, it's not possible to define which of these effects is greater. This means that it's unknown which of these schedules is more toxic, and again, one cannot fit a simple increasing curve. Despite different clinical context of these trials, they both suffer the same problem of unknown order of toxicities. Consequently, such trials require more sophisticated statistical techniques to solve these challenges. Due to the growing interest to such trials, an emerging topic in designing dose-finding clinical trials is a relaxing monotonicity assumption. In the course of work, Project 1 of the IDEAS network aimed to solve these problems and to find new, more efficient ways to conduct advanced clinical trials. Please see our website for proposed solutions and our other projects. Thank you.